Welcome to our webinar. This is one of our monthly series regarding topics that are related to MAT and that you'll see that are relevant to treatment issues you'll see in your clinics. We today our webinar is on continuum of care in addictive disorders, and of course we're primarily interested in opioid use disorders, but really the continuum of care concept applies to really any addictive disorder. So want to go over our outline. So we're first going to talk a little bit about concepts regarding the nature of addiction, and those are closely tied to this concept of a continuum of care. We're going to talk about differential outcomes in the natural course of the disease, but both between different substances and within substances. Then we're going to talk a little bit about differential treatment outcomes, so natural course outcomes and treatment outcomes for different severities and different settings and domains of function. We'll talk a little bit about the ASAM placement criteria, which is one of our structured ways that we determine the proper level of care. We'll talk a little bit about healthcare finance and how that's driving the use of ASAM criteria. We'll talk a little bit about the need for this concept of a continuum of care and the risk that occurs during transitions in care. And then we'll talk a little bit about some of the gaps in Indian country, and we'll end with a clinical vignette, and then we'll walk through how we might determine the level of care for this particular vignette at different points in this person's life. So, and then at the end, we have time for questions. I think I've got 20 slides, so that might take us up to maybe 12:35 or 12:40 or so, and then we can address questions at that point. So, starting with historical concepts of addiction, before the 1980s, when there began to be a real significant advance in functional imaging studies and molecular and cell biology as it pertains to the nervous system, we can only really speculate on the nature of addiction and its causes. Now there was, there's always been some understanding that that addiction is not necessarily unlike other human afflictions, and in fact, like other human medical disorders. And Benjamin Rush, considered the fathers of modern medicine, he proposed that alcohol dependence at the time was there was a medical biological basis to it, though he couldn't really prove that, and this view was not widely held except in some medical services. And then, of course, due to the obvious effects of addiction on behavior, the moral and religious deficiency series really abounded throughout history. Kind of fast forwarding to our current understanding, like many conditions, many of our chronic conditions, certainly addiction causality really fits pretty nicely into a biopsychosocial framework or paradigm. Um, just briefly, there have been family linkage studies and twin studies that have suggested a definite role for inheritance in over the past few decades, and this is something we all kind of get, and in fact the inheritance rate is actually in a huge, there was a huge meta-analysis done about 5 years ago of all of these family linkage studies and twin studies on alcohol dependence, and they found about a 0.5 concordance. So genetic contributions are very significant, which kind of makes sense from a just kind of a sociologic standpoint, and in personal experience, clinical experience. More lately, functional imaging studies and molecular studies, they've really delineated neural networks involved in addiction. The National Institutes of Mental Health and NIDA, National Institutes of Drug Abuse, they've done a lot of studies, funded lots of studies in universities, and they've really they don't have everything figured out, but there's I would say of the things that we know about the brain and behavior, the reward motivation network is one of the best understood. It's quite discrete. That's one of the things from a scientific basis that fascinates me about addiction medicine. And then some of you guys might be familiar with the ACEs study, Adverse Childhood Experiences. That data set has shown that there's a very significant role for early trauma, early childhood trauma, in the development of various disease states, and in particular, addictive disorders. So, I think our modern definition of addiction, kind of speaks to the continuum of care concepts, which is nice. So this is one of my favorite definitions. Addiction is a chronic, relapsing, usually progressive neurobehavioral condition characterized by a dysfunction of the motivation and reward neural network. It's kind of a bit of a mouthful, but it's it really captures a lot of at least the the biological essence of addiction as a condition. And a couple of things points out of this particular definition. It's number one, it's a chronic condition. It needs to be really managed over the course of a lifetime. It's much closer to obesity or even type 2 diabetes than it is, say, an acute appendicitis. It's a spectrum disorder with a huge degree of varying severities and outcomes. It really, comes in all sizes of conditions, and therefore it really requires a variable approach to management. And this is one of the main things that I wanted to get through in this webinar. So just to kind of underscore the fact that different substances, addiction to different substances, can yield very different outcomes. And these outcomes can be in, mortality rate, degree of medical morbidities and injuries. I think most of you guys are familiar with, the medical sequelae of long-term use of alcohol. Can produce, of course, liver pathology up to the point of cirrhosis, esophageal varices, and increased chance of heart disease and cancer and chronic pancreatitis, and pretty much every organ system in the body can be negatively affected by excessive intake of alcohol. And then, of course, there's differential outcomes in terms of social dysfunction between the uses of the substance. So, someone who smokes isn't going to necessarily, be in trouble with their boss unless they're smoking at their desk, or isn't going to lose a relationship or something like they would with cocaine. But so that particular substance doesn't have as much morbidity associated with it as some of the other drugs of abuse. The graph that we have there looks at the differential mortality rates between different substances, and this is potential years of life lost. And so opioids are pretty much the granddaddy of all the substances in terms of mortality rates. If you flip this chart kind of on its head and look at it in terms of life expectancy, assuming the standard 80 years for a US citizen, the average life expectancy of a severe opioid user is about 36 years, which is shocking and really horrifying. And you can see how, the mortality rates then kind of go down from there, still significant. For instance, the average life expectancy for someone with a severe alcohol use disorder is 53, which is disturbing in its own right. All right, so in addition to having differences in severity between substances, there's also differences in severity within a given substance. And this is kind of what I spoke about in addiction being a spectrum disorder. So, you can have with this particular graph is alcohol use disorders, and over on the left-hand side, you've got kind of the degree of drinking, and on the other side, you've got a list of sequelae. And as the use goes up, so does the severity of the consequences on the right. Okay, so one of the important concepts with continuum of care framework is that we want to avoid treatment mismatches for folks. So the research demonstrates some mismatches. We don't have more because there isn't a lot of great research on outcomes in substance use disorder. It's not an easy thing to study, but here's a few of them. It's found that that an adolescent's peer group and whether or not family members use have a very significant effect on the ability to maintain recovery post-residential treatment, which, I mean, that's really common sense. And it's nice to see that research bears out common sense. Another kind of demonstration of disease treatment mismatch that we see in the research is the fact that without, in folks with moderate to severe opioid use disorders, without medication-assisted treatment, folks generally relapse at the rate of about 90% after being finished with a psychosocial program, which is very concerning, and one of the reasons that we've got this huge push to expand medication-assisted treatment is because it is the relapse rate is so high with opioids, and the consequences are so dire. So medication-assisted treatment, as I've kind of discussed in previous presentations, the relapse rate is about 20% at 1 year, 20 to 30% at 1 year, as compared to 90%, which is quite a difference. Another example of a disease treatment mismatch is that structured sober living environments, they've been shown to be efficacious in facilitating long-term recovery in populations that don't have a lot of financial resources. And so what this points to is that if someone has a severe substance use disorder and they have very few resources, there's a good chance that your once a week outpatient therapy is not going to be successful for them, because they face so many triggers and so many challenges, certainly homeless population, but folks that are on the edge, the knife's edge of homelessness, they're at very high risk without some structure in their life. So those are just some examples of the rationale for taking a continuum of care concept and matching the treatment environment to the particular individual. Just kind of some examples. And these are kind of common sense examples. Detox is only necessary in small percentages of folks with alcohol dependence. So, a lot of times, when people think about alcohol treatment, they think about detox, but that's only necessary in folks that have, been drinking hard for 10 years or over, or have some other co-occurring CNS difficulty. Once weekly psychosocial treatment unlikely to be effective for opioid use disorder. As we discussed in the previous slide, you really need pharmacologic support to have a good chance at sustained sobriety. Adolescent is unlikely to be successful at recovery in a house where parents have active, serious substance use disorders. We see that all the time in the Desert Sage Treatment Center. A lot of times we will accept a youth that their substance use disorder may not be as severe as might warrant residential treatment in other situations, but because their recovery environment is so toxic, it really makes sense to get them out of that and help them kind of get a good, clean start on their road to recovery. On the other end of the spectrum, an adult who just began asking for early refills of their Norco, they don't necessarily need to go into residential treatment, and this is all kind of common sense. Wanted to share one example of treatment mismatch, kind of an embarrassing example from early in my training. So this is a little self-disclosure. I was in a family medicine psychiatry residency in Morgantown, West Virginia, and was taking psychiatry call in the ER, and there was an individual who came in without a shirt, and he had one of those Joker hats on that has little bells on the end of it, and it was quite a sight, and his behavior was pretty silly. He was bowing to the nurses and kind of silly things like that. And he was very intoxicated with cannabis. He didn't have any other substance use disorders, but basically he was, kind of blazed out of his gourd. In a case like that, the appropriate management would be to make sure that he's not medically compromised at all, that he's not psychotic, there's no thoughts of suicide or no aggression. So you do your evaluation for safety, and of course your medical evaluation, and then you try to get him to get to see a substance use specialist, maybe the next day. And in his case, there was a girlfriend with him who probably would have helped him get there. But I had reason that, number one, it was in the winter and he was out without a shirt, and so I was kind of concerned that he might go out there and freeze. So and then the other part was, he was acting pretty silly, and I was afraid that maybe he might get himself into some trouble with folks. So I ended up recommending involuntary hospitalization, and at that time, early 90s in West Virginia, involuntary hospitalization was it was a little different than in most states. First of all, there's a court that convenes at the time, so there were a number of judges that came in for this, and so we had a hearing in the emergency room, at 2 o'clock, 3 o'clock in the morning. And I made the argument that this person needed to be involuntarily committed. And basically they sent him to the state hospital, which was where all the involuntary commitments go. And it's a 30-day commitment. Now, what I hope happened, kind of looking back, is that he got there and they said, this is, silly that we've got someone who was just, intoxicated with cannabis, and let him go. So just in my defense, it was 2 or 3 in the morning, and I did get woken up out of a nice bed. So no, I'm just kidding on that. So that was not good medical decision making. That was an example of a mismatch between the disease and what would be the appropriate treatment in this case. And in this case, looking back, I've many times regretted the fact that at least for some period of time I restricted this individual's liberty, which is, I think, something that we all have to take very seriously. All right, so enough of that. Okay, so moving on to the to ASAM criteria, which is one of the ways that we structure information to make good decisions about placement. And so the ASAM system basically looks at functional domains. So as you can see, there are 6 domains. The first domain, or sometimes they're called dimensions, is the presence or absence of acute intoxication or the likelihood of withdrawal. Next is biomedical conditions. So, this is, primarily the person's medical stability. Dimension 3 is really their co-occurring psychiatric conditions or, current emotional state. Dimension 4 is their readiness to change. So, of course, motivation is incredibly important in someone's success, and so it's important to look at that that particular domain. Dimension 5, it's basically looks at the person's history of treatment and how effective they were at previous episodes of treatment, whether they are at high risk of relapse based on their history. And then domain 6 is looking at their environment and whether it's a recovery supporting environment or one that is going to be really working against the individual in their efforts to maintain recovery. So we look at these dimensions, and each domain gets a score. It's actually 0 to 4, not 1 to 4, but each domain gets a risk rating of 0 to 4. So that's the domains that we look at, and basically after you look at these domains, it kind of leads you to a placement level. So kind of an ideal setting for this person's treatment. And the ASAM has 4 levels of treatment, actually 5 if you consider early intervention, and that's really screening. So your expert screening or other alcohol screening efforts would fall into that category. Level 1 is outpatient. Level 2 is intensive outpatient or partial hospitalization. Residential is number 3. Level 3 services, and there's several sub-levels within there, kind of depending upon the intensity of treatment that's offered at a particular facility, and of course, matching it up to what the person's needs are. And then level 4 is basically a hospital that is fully equipped to handle all medical issues and psychiatric issues. So those are the 4 levels, 1, 2, 3, and 4. There are a number of screening tools that help, that are in question and answer format. You go through these questionnaires and ask patients things that really drill down on the domains of function, and then it usually gives you a score at the end. And many times, usually it's in either the ASAM level that it gives you a response or something close to it. One of the more highly used screening tools is the Addiction Severity Index, the ASI, and that doesn't give necessarily an ASAM level, but the report that it gives lines up more or less with ASAM criteria, and you can make a reasonable placement decision out of it. There's all kinds of them. There's there are models, tools that take an hour, then they come in some brief forms as well that can take 5 to 10 minutes. And I'm not going to go into any more detail on this. There's a, because there's a lot out there, and I can, if you're interested, I can, send you some links on them. Okay. So kind of going back to the continuum of care concept, again, in recognition of the fact that a person's disease can change in character, in intensity, and that they move through different environmental contexts over the course of their lifetime. Really, you need to have a variety of treatment levels to really address a person's condition at any point in time. There's a lot of funders now that are requiring the use of ASAM criteria. The state's drug Medi-Cal system is actually requiring the use of ASAM for placement decisions at the level 3 level or higher. Sometimes funders will require failure at a lower level of care to progress to a higher one. This is kind of consistent with the least restrictive environment concept, which, going back to the fact that people's, liberties are important. That's an important concept. And then kind of a corollary to the continuum of care concept is that there really needs to be a mechanism for transitioning between levels of care, or sometimes refer to them as episodes of care. And reason for that is that these transitions are generally very high risk periods for a patient. If a patient's going to relapse, there's a good chance that they're going to fall through the cracks in one of the transition states. So, when they're discharged from residential care, or, if you're trying to get them from the outpatient program into a residential facility, those are risky times for folks, and really are times when you really need to do some very aggressive case management. All right. Just wanted to touch on some of the treatment gaps that that currently exist in Indian country. There's we've got a lot of ASAM level 1 services, which is fantastic. All of our Indian, at least our comprehensive ambulatory care clinics in Indian country, I think, except 1 or 2, have behavioral health departments. Let's see, I just got a question about the slides, and yes, you are supposed to be able to see them. Can I get a show of hands of if anyone else cannot see the slide? Okay, you cannot see the slide. Okay. All right. Okay. All right. Okay. I am very sorry for that. Looks like I forgot to share it. Okay. So again, my apologies. Okay. Mostly there wasn't a whole lot of diagrams, and except for in the beginning, there are a few diagrams, and most of it I mentioned verbally, but yeah, sorry about that. And thanks for letting me know. All right, so everyone can see it now. So going back to the treatment gaps in Indian country, there are very few level 2 programs, so intensive outpatient or partial hospitalization programs, sometimes referred to as day treatment programs. There's not a whole lot of these in Indian country. There's maybe 3 or 4 of them. A couple of them are associated with our residential treatment programs, and so very few ambulatory care programs have one readily available. Now there are some of our Indian health programs that do have contract relationships with some intensive outpatient programs, but it's not ideal. So an intensive outpatient program, basically it's obviously an outpatient program that provides, in the case of adolescents, a minimum of 6 hours a week of treatment, and for adults, 9 hours of treatment. And a lot of times they'll divide it up into different days. Sometimes it's a Monday, Wednesday, Friday. A lot of times it'll be in the afternoon, so people can go to work or go to school and still participate. These are, I'm a big fan of these because for a number of reasons. They have several advantages, including they allow people to continue their roles as caregivers and earners. There's not a whole lot of us can take time off of work to take 6 to 8 weeks off of work. It's hard for most of us financially, so it allows them to do that. Allows for in vivo testing or kind of real live testing of new skills, because you're in your natural environment and still going to still getting these intensive treatment services. And it allows for, kind of related to that, allows for more family contact, which can be very important, at least in some cases. And then another treatment gap in Indian country is there's, sometimes lacking some of the adjuncts to a large comprehensive behavioral health program, such as case management. Sometimes there's almost never enough case management, contacting folks and following them up and that kind of thing. Social skills training, sometimes that's hard to get in an outpatient setting. Psychiatric addiction medicine services are not always easy to get. So there's a few treatment gaps in Indian country. So I'm going to go through a case example highlighting the continuum of care concept. So we're going to talk about Elijah, and we're going to be introduced to Elijah while he's in high school. So Elijah's suspended for school for being caught smoking marijuana, and he had some pills in his possession. He's actually not quite sure what they were. He says he hasn't taken them but a couple of times. His mom is a tribal judge, and his father is a professor at a local community college. Father, he does have a family history of addiction. His father is in recovery for alcohol use disorder. Both Elijah's parents take the issue of his suspension very seriously, and because of the family history, they're worried about him, and they really respond aggressively, and they bring him in basically to treatment. He's, at this point he's been suspended, so he's, feels chastised and goes along with mom and dad as they bring him into clinic. And with the support of his parents and high school coaches, Elijah stops using marijuana and never uses pills again during his high school career. So fast forward, Elijah's now 21. He is at a major West Coast university, and he is a very good collegiate wrestler. But he has a severe tear in his anterior cruciate ligament. That's a ligament in the knee, and he has surgery, hoping that that might save his career. After surgery, he's prescribed hydrocodone for pain, and begins to use increasing amounts beyond what's necessary to control his physical pain. He later learns that he's not going to be able to wrestle at the same level, and coaches offer to put him on the red shirt list, and tell him maybe he can get back into it next year. But he's pretty demoralized, and as a result of his demoralization, he actually starts overusing his hydrocodone even more, because it kind of addresses the pain of missing his big chance at the Pac-10 finals. When his primary care provider begins to taper him off, he begins to buy oral opioids from his friends in college. Now he's no longer on the wrestling team. He loses his scholarship. Basically tells his coach, look, I'm not going to be able to wrestle at the same level anymore, so I'm done. Loses scholarship, and now his parents choose to help him with his tuition. But as a condition, they want to see his last grades, and because he began overtaking his pills during the previous academic period, they're not so good. And he admits to what he had been doing, and his parents encourage him to get an appointment as soon as, this is during the summer, so as soon as school starts, get an appointment with Student Health Services. And so he does that. Student Health refers him to a local addiction medicine practice. They place him on Suboxone and refer him to a brief course of an intensive outpatient treatment. And he does does well for several years at that point. So now, 10 years later, Elijah is a 31-year-old junior partner at a law firm in Seattle. It's one of these big corporate, high-pressure firms, and he gets passed over for senior partner. He's a little young for senior partner, but he's really talented. He's a mover and shaker, and when he gets passed over, he really gets depressed and feels bad. To make matters worse, he's been fighting with his fiance, and because of the stress about if he's going to get the job or not, and he's irritable, and fiance leaves him, and he begins drinking really heavily, and then ends up relapsing on oral opioids. Comes very depressed. He misses a few important court dates with big corporate clients, and ends up getting fired from the firm. As I mentioned before, he had gone off Suboxone 4 years previous, and really begins using oral opioids heavily. He ends up moving in with his folks, moves out of Washington State, back with his folks. They live near the reservation in California, where mom works. He's got very limited finances at this point, and with oral opioids being so expensive, he begins smoking heroin. He kind of hooks up with some cousins that are using, and they have a ready supply to black tar heroin, and he starts using that on a regular basis. After 6 months, his parents find his paraphernalia and insist that he get help as a condition of continuing to live there. They kind of do a tough love thing. So he's still depressed. He reluctantly goes for an evaluation, but he misses a lot of appointments. Part of it is he just doesn't have his heart into it. He just has a hard time just motivating himself for anything. He gets prescribed buprenorphine, naloxone, and an SSRI, but just doesn't take it because he's still kind of demoralized. Finally, after several weeks, weeks to months of outpatient therapy in which he's not engaged very well, he gets referred to residential treatment. Doesn't want to go, but his substance abuse counselor is pretty tenacious and really kind of gets him in and sort of seizes the opportunity and gets him there to the residential treatment center. On admission, his clinical opioid withdrawal scale, and I'll we'll expand more on that at a different time, is in the mild to moderate range. They start him on an SSRI and start him back on Suboxone. And after 60 days in treatment, he reconnects with his traditional Native American spirituality that he learned when he was young and does well. After being discharged from the 90-day program, he immediately resumes outpatient treatment at his home clinic. He gets a job as legal counsel at a neighboring tribe, and he begins coaching high school wrestling, something that he really loves. And he then begins attending White Bison regularly at his home reservation, and stays on the buprenorphine naloxone. After a couple of years, he's doing well, and he ends up going off as antidepressant. And because he's built in a lot of stress relievers and positive relationships, over time he does okay without an antidepressant. So we're going to look at what the ASAM criteria says at different episodes of care. So here's the domains: intoxication, withdrawal, medical, mental health, psychiatric, readiness, relapse potential, environment. And so looking at his first, and if you want, well, let's see, I'll just to save time, I won't go back there. But basically he, didn't have any, wasn't intoxicated, no withdrawal potential. He's his resistance to change. So this is 1 to 4, with 4 being resistant. So, he's not very resistant, not a very high relapse potential. And so outpatient therapy is appropriate for him, and that's basically what he gets. His second major episode, he is now using opioids, and even though he hasn't used them for too long, he still, upon cessation of their use, he does have some withdrawal symptoms, and so he's got a higher score in his withdrawal. Still healthy guy, nothing there. He's distressed. He started using, as a matter of fact, because of his distress about his wrestling career. So he's got some of that, even though no formal diagnosis. He's a little more resistant to change. He's part of it is that he's been without opioids for a while and knows that withdrawal is really unpleasant, so a little more resistant to change. He's got a little bit more relapse potential this time, and he's in college. He's he's got supportive folks, but he's in college. He's got friends that use, so environment isn't perfect. It's not horrible, but not perfect. The intensive outpatient program, really helps with the environment. So that's he's got modest scores in most of his domains. So looking at his third relapse, major relapse, he's been using heroin for quite a while and opioids in general for quite a while. So now his withdrawal score is pretty high. And he had that COWS on admission of 19, pretty significant. Still healthy, no problems. But at this point, he's depressed, so he's got significant mental health comorbidities, and we've seen that his depression has affected his willingness to engage in treatment. So he's suffering there. He's just kind of demoralized. He kind of connected finally with some cousins, even though it's over drugs. He still hasn't had a connection for a while, and so partially resistant to change because of that. He's relapsed a couple of times. His recovery environment is not great. He's got his folks, but he's also got some relatives that use, and so, but he's got enough elevated scores in enough areas that residential treatment is really appropriate for Elijah at this point. So we kind of look at, through the course of his life, with the progression of his disease, he needs different treatment at different points in time. So just kind of a summary, continuum of care. It's an important framework for viewing the disease. And it has practical value in decision-making. Transition in levels of care remember, those are very high-risk periods and they need extra support. And then ASAM criteria really provide a good structured means of determining the appropriate level of care by looking at domains, functional domains. All right, so that is it